Okay, Assalamu alaikum. Actually, the topic which I want to discuss today is with reference to amputation and the immediate effect of amputation, which is evident in the form of the development of post uh, amputation pain, like that is phantom limb pain. Okay, so if we just think that, just a second.
তোমার কি খাবার হয়ে গেছে?
Okay, so what do you think for which will be the conditions which will lead to amputation of limb or amputation of any body part? Anyone, please? Actually, usually it will be either any condition in which there is ischemia. Okay, my stylus was not working. I will just try to write it. Ischemia, gangrene, electrocution. Okay, vasculitis. Uh, like gangrene, maybe gas gangrene, gangrene may be related to as a general part of sepsis, and ischemia with reference to cold, with reference to high, can you people mute yourself, please? Okay, high vasopressors. Okay, like this may be the common things in which it will result in vascular insufficiency, and yes, embolization, resulting in ischemia of, like, there is some thrombus in any vasculature of the like lower limb or upper limb, resulting in very, like, not very common, but if you did arterial line, okay, and then it is resulting in ischemia, and if it is not treated, it can result in gangrene and leading to amputation. So whenever you receive a call that you have an amputation, it may be of lower body part or like maybe digits, and then you can come up to foot or then below knee amputation or above knee amputation. Okay. So usually whenever there may be, can anyone add into this list? Anyone, please? Which will be resulting in amputation? Yes, anyone, please? Zubair bhai, would you like to add something?
Joined. So let me see what is going on.
Like this is like we are trying to discuss amputation and then correlation between amputation to prevention of phantom limb pain. Okay, so like I just said that any cause which is resulting in ischemia, it may be acute ischemic event, it may be like chronic vascular disease, and then there will be some development of infection because of, for example, diabetic patient or any cause of sepsis, patients on high vasopressors, and development in gangrene. Then one of them is electrocution. Okay, and then cold, like people frostbite who develop, so they may result in amputation.
Trauma.
Okay. Trauma. Okay. Trauma resulting in vascular
trauma, thrombosis.
Trauma resulting in vascular insufficiency, okay, and then like leading to of course end result is ischemia and loss of the metabolism, and but causes so whenever you receive a call that the patient is going for amputation, you should rule out what is the cause, because there may be it may be a tip of iceberg. If you have a patient with peripheral vascular disease, you expect that this patient will have the chances of cerebral vascular disease, ischemic heart disease, so you will be anticipating accordingly. Okay, so if you have a patient with electrocution, things will be different. So whenever you receive a call for amputation, you should be knowing which extent of amputation it is, and what is the events leading to this result in which they have to remove it. Okay. Another thing which is with reference to phantom limb. Yes, yes.
Tourniquets?
Yes, yes. Okay. Tourniquet is, yes, you are absolutely right. Okay. So tourniquet, whenever there will be tourniquet, it will be resulting in another condition associated with, before that is rhabdomyolysis. Okay. So rhabdomyolysis and ARF. So this should be in your mind as well. So okay, so there is some other conditions which are also our risk factors for development of phantom limb. Actually, it is with reference of phantom limb pain, but actually mastectomy. Okay, even testicular removal. And what else? There is one more condition I am just trying to recall, which can also result in a pain like phantom limb pain. Okay. So this is the background of what we, okay. So during, for example, conduct of anesthesia, what should be the priorities? Okay. Usually you can give some block, okay, with either it is a central neuraxial block with reference to yeah, one thing, and one thing also clicked in my mind is intra arterial injection resulting in thrombosis. Okay, with reference to, for example, thiopentone. Okay, so whether it will be central neuraxial block or even peripheral nerve block. Okay. So there will be even in this procedure, there will be presence of tourniquet in majority of cases. Okay. So whenever there is some infection, so people give spinal or epidural in infective cause, but you have to think that this patient will be at risk of development of epidural hematoma or abscess. So you have to outweigh risk versus benefit. Okay. So if you have any doubt, you should not perform, especially epidural, because the spinal will be with a very thin gauge needle, pencil point needle, so there is less risk of development of hematoma, but still there are more chances of development of epidural abscess if there is a risk factor, like for example diabetes is a risk factor, sepsis is a risk factor, so you have to be careful about it. Okay. Then the concerns related to tourniquet. Whenever you are putting a tourniquet, you should be knowing that all the sequelae which will occur with the tourniquet. So tourniquet pressure, tourniquet time, tourniquet pain, tourniquet release. Okay. So all the concerns with reference to tourniquet. Even if they are removing any part, maybe the anesthesia you are planning to give will be covering the area of in CN and everything, but you should be knowing that you have to cover the area of tourniquet as well. Okay. So another very important thing will be that whenever it will be depending on the extent of amputation, but it will be having some blood in it. Okay. When they finally remove it, so there will be, according to the limb they are removing, there will be blood loss accordingly. Okay. And even if they have put tourniquet, there are chances of bleeding. So of course, these patients, especially if they have infective cause or diabetic, maybe there is pre-existing anemia, especially if it is with the combination of trauma and generalized bleeding or something like that. So you have to be very careful that although your concentration is only on amputation, but you have to think about the side orders which are there. So bleeding will be one of the thing. Then it's when they are removing it, especially when they are cutting, it's a very painful procedure, especially when they are cutting the bone. Okay. And there are chances of even fat embolism when they are cutting at that time. Like, you have to be mentally prepared for everything. And there will be redistribution of blood, especially when they open the tourniquet. So these will be the things like level of if it is, for example, above knee amputation, the morbidity will be more as compared to if it is only removal of digit or removal of foot or removal of, especially similarly in the upper limb. Okay. So this is one of aspect of the discussion. And the other aspect of the discussion will be with reference to the factors which will be leading to phantom limb pain. Okay. So can anyone tell that what are the, like, how phantom limb pain develops? Or because of course phantom limb pain is mainly the domain of chronic pain people, but are there any factors which you can do to prevent the happening of phantom limb pain? So one of the most important factor is acute pain management. Okay. If, for example, there will be a big psychological trauma, so maybe you can consider pregabalin. Okay. Even preoperatively, this is one of the thing. You can place an epidural, especially if it is lower limb. You can place epidural, you can start pregabalin. Okay. And you can use nerve blocks whenever possible. Nerve blocks. Okay. Like, if like actually today I did a case, and there so I give combined popliteal and femoral nerve block. That patient had refused epidural, but actually if there is ischemia, there is patient is already painful. So it is if there is no contraindication with in that case you can put epidural. Oh, it will be one of the thing to prevent the development of phantom limb pain. Okay. Multimodal analgesia. So multimodal analgesia is with this is my topic of interest, with opioid-free techniques, a lot of things like dexmedetomidine. Okay. Lidocaine infusion whenever possible, ketamine. Okay. And then there is role of magnesium sulfate, in addition to the normal routine paracetamol, NSAIDs, and opioids, of course, are not like contraindicated. But if you are using a technique for your trend is because there is a growing trend of use of opioid-free anesthesia. And I am a big advocate of that technique. And actually, I have reduced opioids as much as possible for me with reference of this with virtue of dexmedetomidine, ketamine, lidocaine, in a different way. Okay. And use of paracetamol and NSAIDs, and even local infiltration, wound catheters. These all will be techniques by which you can have you have the WHO ladder for acute pain. So which is because the difference between the WHO ladder for chronic pain is from starting from minimum and then growing up. And the WHO ladder for acute pain is the reverse direction. You start with the maximum, and then you come down. Okay. So you have to start with all these stuff which I've told in a combination, and then you gradually come down. Okay. And anxiolysis, and as I told you, roles of antidepressants, and this anti-epileptics like pregabalin. Okay. Pregabalin, gabapentin. So these are because there are some factors which are related to the performance of amputation, but there are a number of factors which are with reference to the technique which they are using and how you are managing that patient overall. Because there are some other ways for there is a mechanism of mapping. Sorry, this one mirror therapy. Okay, mirror therapy which they start because there is remapping problem, and so it will be leading to development of amputation pain. But one of the biggest factor which is treatable, because if there is some psychiatric condition which is developing, maybe is not in your hand, but treating acute pain very well is one of the factor which you can do. Okay, psychological support. I still remember I was just doing my house job internship way back in 2004, and I cannot forget maybe a teenager who had electrocution. And can you believe this, that they were removing his one by one all his four limbs. And I was very junior. I was short of words. I was short of ideas, because in that setting, when I was giving him anesthesia along with my senior colleague, it was bilateral below knee amputation. But after that, his hands were arms were also gangrene, and they were planning for removal of that one as well. I did not have any words to talk to him. So it is a big psychological trauma. So that's why it's, if you want to avoid happening of phantom limb pain, you have to be very meticulous, and you have to treat all the factors which may lead to development of phantom limb pain. So up till now, I have just peeped into some of the factors. So we will just try to have how phantom limb pain develop. So because there is some peripheral mechanism which occur because of denervation, and then abnormal development of neuromas. Okay, and there is some modulation problems of modulation in the spinal cord, and then there is development of errors in the remapping, because there are specific areas in the brain which are which are responding to the different body parts. So when some of the part is removed, there is remapping. So there is error in remapping mechanism, and then patient is thinking that there is still missing limb or phantom, which we use, that phantom part is there. Okay. So it's a very high incidence. Around 60 to 80% of amputees will experience phantom pain. Okay. So just etiology. So peripheral mechanism, as I told you, when they are cutting, there is a severing of peripheral nerve axons and formation of neuromas. Okay. And disorganized endings of C fibers and demyelinated A fibers, A delta fibers. So neuromas have been shown to demonstrate abnormal spontaneous evoked activity that is thought to be due to fundamental changes in ionic channel. This is the details for, there is some spinal mechanism. Okay. After nerve injury, there is increase in excitability of spinal cord neurons characterized by abnormal spontaneous activity and exaggerated response to mechanical thermal stimuli. Sensitization of dorsal horn neurons occurs in response to increased painful stimulus. By the way, this is the place where the gate control theory works. So there is actually, instead of closing the door, there may be hyperexcitability. So it will be like development of hyperalgesia. And that's why the role of ketamine is of utmost, even in tourniquet pain. NMDA receptor antagonist like ketamine has great role. Okay. And the central mechanism, as I told you before, there is reorganization of primary somatosensory and motor cortices and subcortical structures, areas of somatosensory cortex which previously corresponding to the missing link subsequently receive sensory stimulus information from other areas of body that synapse at the adjacent areas on somatosensory cortex. It is thought that phantom pain may be a consequence of error occurring in remapping process. Okay. So that's what is the mechanism. So prevention, as I discussed, the basic principles that you treat the acute pain. Okay. A popular theory has been to preemptive analgesia. The constant supranormal nociceptive input from an amputated limb is thought to contribute to the neural reorganization, which may lead to phantom limb phenomena. As I told you, preemptive analgesia and multimodal use of multimodal analgesia, was there. And see, epidural placement incidence will be decreased, but overall severe pain will be decreased, but overall incidence you cannot control 100%. But you can use a number of techniques. Okay, so one of them epidural, and also placement of perineural catheters either pre or intraoperatively. Administration of local anesthetic at the time of amputation, and as a continuous infusion, as I told you, wound catheters and the catheters in the area. So other medications will be antidepressants, gabapentin, pregabalin, okay, opioids. There are some novel techniques like calcium. I've no idea about it, how they use it, but they have written here calcitonin to be effective in treating phantom pain if given early in the post-operative period. This is a clinically well-tolerated agent that can be administered as subcutaneous injection. I have no idea about it. This is something maybe I don't. Anyways, so mirror therapy, they are showing with the imaginary image, and this helps in prevention. And the rest of the techniques, acupuncture, TENS, stump care, psychological therapies. Okay, so I have discussed actually before phantom limb pain separately as well. So that's what I just wanted to discuss. Any comments, any questions anyone wants to add on?
Sir, how soon can phantom limb pain develop after amputation?
Actually, I have never encountered it, so I have no idea. Maybe I think it can develop as early as post-operative period, if I'm not wrong. Because initially it will be in the form of stump pain, and then it will be continued. Okay. Any comments from the house? I don't have the exact answer to
I
this
think you're right.
question.
I think you're right, because there's an MCQ also about it, that if a patient has developed phantom limb pain and he
Okay.
has come for surgery for refashioning of the stoma or like that, which will be the preferred technique for anesthesia,
So I think
regional or
regional will be
GA.
better.
And in that
Regional.
regional is not good, because they say that if he has phantom limb pain, he will still yes.
Regional will
Will be
not be
better.
good. I'm not sure.
No, sir. It won't be good, because
Your voice is
what I
cut.
remember is the reason they told that regional is not good, because they said that if he has
Your sound is breaking, Zishan.
Can you hear me now?
Yes, please.
Can you hear me now?
Yes, we can hear you.
Okay, so the regional is not good, because they say that if he has developed phantom limb pain during regional, when he will be awake, he will still be complaining of pain. So
okay,
if phantom limb is already there, general anesthesia should be preferred.
okay. Like it is in the case when phantom limb pain has already been developed.
Yes, sir. Yes, sir.
Okay, so this is a FRCA mind map. It is a very good way. I will suggest all of you to make mind maps like this. Whenever you are studying a topic, try to have like points like this. So you see the risk factors: pre-amputation pain, one of the biggest factor; persistent stump pain; bilateral amputation. Okay, lower leg amputations less frequent in children. Incidence may be as high as 50 to 75% normally occur in the first week. Okay, can be exacerbated by central nervous block or even precipitated by a small block. This is, you see, this is
What about the regional?
Yes, please.
What about the region?
I'm sorry, your voice is closed. I could say it again, please. I think the connection is not stable on my side. Actually, I don't have the correct this point. I cannot explain because they have written can be exacerbated by a central nervous block or even precipitated by spinal block. This is something like my concept was a little bit different.
Yeah, that's why the phantom limb pain patient has a phantom limb pain. But can we do? Can it be the good idea regional anesthesia with the sedation, like ketamine or propofol infusion or some heavy opioids or sedatives,
Actually, you are
rather
absolutely
than
right.
rather than the general anesthesia?
Actually, the points which I highlighted were more related to the prevention, because in my life I have never encountered a patient with phantom limb pain. So unfortunately, the things which you practically don't perform, sometimes there is a gap in your practical knowledge. So I'm short of practical knowledge about this topic. Okay. So because in now, in Saudi Arabia, we are not dealing chronic pain. So I lack a little bit. So I have no idea. I need to confirm it. Rather, this point is a little disturbing for me because it is against what concept I had. Okay. I had a little different concept with reference to prevention more than anything else. Okay. I will just try to engage some of the people who are treating phantom limb pain, um, so that we have this missing link of the patients, because my talk and my discussion was more focusing on the prevention part. Okay, say now if the patient already has developed phantom limb pain and now they are going for any surgery, like revision or anything, how to treat it or how to conduct anesthesia. This is a little bit doubt tricky topic. Okay, so I think that's it from my side, and thanks a lot all of you for your presence.
Thank you.